Okay. Now, what is anaphylaxis? Anaphylaxis is a potentially life-threatening systemic allergic reaction characterized by circulatory collapse, bronchospasm, laryngeal stridor, and often associated with angioedema and urticaria. Anaphylaxis occurs when an allergen binds to and across links membrane-bound immunoglobulin E on the mast cell in a susceptible individual, causing release of histamine, tryptase, and other vasoactive mediators from the mast cell. These mediators have a variety of effects, including vasodilatation, increased capillary permeability, leading to hypotension and bronchoconstriction, among other manifestations. Causes of anaphylaxis. Anaphylaxis may be caused by food, such as peanuts, fish, milk, eggs, and soy products. ولذلك انتم تشوفون على الشغلات المصنعة مكتوبة it contains egg, it contains milk, it contains peanuts, ويخلوها bold letters. مرات حتى يقول may contain traces of flanchy in order to alarm those who will eat it that this contain an allergy. Insect stings مثل البي venom عضة النحلة. Chemicals, drugs, and other foreign proteins, مثلا intravenous anesthetic agents, penicillin, and other antibiotics. وهاي تسامعين بالبنسلين الرجي اللي اخذتوها بالهيستوري يعني. لاتكس اللي تصنع من عند المواد مثلا examination gloves, Foley catheter. عندنا other reaction similar to anaphylaxis, and it can be difficult to distinguish it from anaphylaxis. It is this Ige mediated anaphylaxis is difficult to be distinguished from the non-specific degranulation of mast cell on exposure to drugs and chemicals or other triggers where the Ige is not involved previously, and this was previously known as anaphylactoid reaction. يعني عندنا شيء آخر هذا الانافيلاكتويد ما يشمل الامينوجلوبولين اي ضمن الباثوفيزيولوجي مالته، بس it has تقريبا similar mechanism يشبه ايضا يصير عندنا mast cell degranulation without involvement of IgE. ايضا it involves drugs like aspirin, opiates, radio contrast media, exercise, cold, and sometimes there is no cause identified in 20% of patients. Clinical assessment. You may see that the patient is feeling of impending doom. He may lose consciousness. He may have conjunctival injection on swelling, flushing, sweating, wheezes, and bronchoconstriction. Frequently, you will have hypotension, urticaria. You will have wheals here of urticaria over the skin, over the arms and other part of the body. Angioedema of the lips and the mucous membrane, laryngeal obstruction and stridor. ممكن نلقي الكوز اللي هو الواسب sting عضة النحلة مثلا on the skin of the patient. The patient may have cardiac arrhythmia, abdominal pain, diarrhea, itching, etc. اللي يهمنا هنا اللارنجيال اوبستراكشن كلش مهم، والهايبوتنشن كلش مهم، والويزس مهمه، وطبعا الكاردياك اريثميا. الموست كومن تريجرز مثل ما قلنا هو food, latex and insect venoms. History of previous local allergic responses to the offending agent is common in anaphylaxis. The route of allergen exposure may influence the principal clinical feature. مثلا, if the allergen is inhaled, the major symptom will be wheezing. Features of anaphylaxis may overlap with direct toxic effect of drugs and venoms. اكو مرات ان شاء الله تاخذوها، يمكن اخذتوها بالتوكسيكولوجي. Drugs and venoms will have its own chemical direct effect without inducing anaphylaxis. فأيضا يعني هاي الكلينيكال feature راح تلقي clinical feature of the direct effect and the clinical features of anaphylaxis if the drugs caused anaphylaxis. There are potentiating factors such as exercise and alcohol, and this can lower the threshold of the anaphylactic event. What is the differential diagnosis? Anaphylaxis should be differentiated from vasovagal syncope, cardiac arrhythmia, cardiogenic shock, status asthmaticus, pulmonary embolism, C1 inhibitory deficiency اللي راح تسوي لنا laryngeal obstruction and angioedema, idiopathic angioedema, systemic mastocytosis, carcinoid syndrome, and pheochromocytoma. Investigations. Measurement of serum mast cell tryptase concentration is useful to confirm the diagnosis but cannot distinguish anaphylaxis from anaphylactoid reaction. Specific IgE tests may be helpful in confirming hypersensitivity and may be preferable to skin prick test when investigating patients with a history of anaphylaxis. Emergency management. الامرجنسي مانجمنت هذه كلش مهمة، تركزون عليها زين، كلش مهمة بالامتحان. You should prevent further contact with allergy so that you will prevent the ongoing mast cell activation. You should ensure the airway patency to prevent hypoxia. Then administer epinephrine or adrenaline promptly in a dose of 0.3 to 1 ml of 1 إلى 1000, 1 to 1000 solution intramuscularly in adult, and this is repeated at 5 to 10 minutes interval if initial response is inadequate. The intramuscular route is important because of the peripheral vasoconstriction acts within the and this acts within minutes. It increases blood pressure and reverses bronchospasm. Administer antihistamine اللي هو راح يكون chlorpheniramine 10 mg intramuscularly or slow IV injection. It blocks the effect of histamine on target cells. And administer glucocorticoids in the form of hydrocortisone 200 mg intravenously, and this reduces the cytokine release and prevents the rebound symptoms in severe cases. provide treatment such as nebulized B2 agonist, مثلا salbutamol, which reverses the bronchospasm, and IV fluid to restore the plasma volume, and oxygen to reverse hypoxia. تركزون على هذا كلش زين. اكو سؤال هنا؟ اوكي.
شكرا دكتور.
We come to part of immunodeficiency. نبدي بال primary phagocyte deficiencies. Most of them are genetic, have genetic causes, and usually they present in the childhood. The first part of chronic granulomatous disease is characterized by failure of oxidative killing, which leads to susceptibility to catalase positive organisms such as staph, Burkholderia, and Aspergillus. Infections most commonly involve the lungs, lymph nodes, soft tissue, bone, skin, and urinary tract, and are characterized histologically by granulomation. من اسمه chronic granulomatous disease. Most of the cases are X-linked. The second primary phagocyte deficiency disease is leukocyte adhesion disease. They are characterized by recurrent bacterial infection, but the site of infection lack the evidence of neutrophil infiltration, such as the pus formation. يعني شنو؟ يعني احنا عندنا التهاب، نتوقع انه الالتهاب ب نيوتروفيل، وهاي النيوتروفيل راح تسوي لنا pus اللي هي الجراحه. بس نجي نشوف site of infection there is no pus. Peripheral blood neutrophil count may be very high. اللي يصير انه عندك نيوتروفيل عاليه بالدم، بس هاي النيوتروفيل ما تطلع تروح للسايت اوف انفكشن because of this adhesion deficiencies and the failure of this neutrophil to be mobilized to exit blood vessels. اللي يصير continuous stimulation to the bone marrow to produce more neutrophils. The number of neutrophils will be very high, but they don't act because they cannot reach the site. Specialized tests show reduced or absent expression of adhesion molecules or neutrophils. The third primary phagocyte deficiencies disease are the defects in cytokines and cytokine receptors, and these are characterized by mutation in the gene encoding cytokines such as interferon gamma, interleukin 12, interleukin 23, or their receptors. And these result in the failure of intracellular killing by macrophages and affected individuals are particularly susceptible to mycobacterial infection, يعني TB مثلا. Okay. خلص primary phagocyte deficiency. other immunodeficiency disease هو complement pathway deficiencies. These are characterized by loss of function mutations which have been identified in almost all the complement pathway proteins. Complement deficiencies are rare باستثناء mannose binding lectin deficiency, which is common. Clinical features include recurrent infection with encapsulated bacteria, particularly Neisseria. لأنه الكومبلمنت مهم بالimmunity against the encapsulated bacteria, such as Neisseria and meningococci. وبنفس الوقت هذا الديفيشنسي complement راح increases the possibility of the body to develop autoimmune disease such as SLE. Those who have complement 1, complement 2, and complement 4 deficiencies. Individuals with mannose binding lectin deficiency have an increased incidence of bacterial infections if subjected to an additional cause of immune compromise such as premature birth or chemotherapy. وعادة ذول يكونون asymptomatic إلا لما يتعرضون إلى شيء آخر. Deficiency of the regulatory protein CI inhibitor is not associated with recurrent infections, but causes recurrent and how will we investigate? First, we should screen the patient. لما نقدر نسوي the whole complement. There are certain tests نسميهم hemolytic tests. These are specialized functional screening tests of the complement-mediated hemolysis known as CH50 أو classical hemolytic pathway 50 and AP50 اللي هو alternative pathway 50 tests. إذا abnormal, they should be followed by individual complement component investigation. Management. Patient with complement deficiency should be vaccinated against meningococcal, pneumococcal, and anti-influenza Haemophilus influenza B vaccine to boost their adaptive immune responses. These are the encapsulated microorganisms. And lifelong prophylactic penicillin is required to prevent meningococcal infection. Those family members who are at risk should be screened. The third part of the immune deficiency diseases is the disease affecting the antibody deficiencies, called primary antibody deficiencies. Primary antibody deficiencies occur as a result of abnormalities in B cell function. They are characterized by recurrent bacterial infections, particularly of the respiratory and gastrointestinal tract. The most common causative organisms are encapsulated bacteria such as strep pneumoniae and H. influenzae. These disorders usually present in infancy when the protective benefit of the placental transfer of maternal immunoglobulins has waned. Examples: X-linked gamma globulinemia, selective IgA deficiency, functional IgG antibody deficiency, common variable immune deficiency. هنعلق عليه شوية. This presents with recurrent infections and bronchiectasis, and which are the recognized complications. Antibody-mediated autoimmune disease such as idiopathic thrombocytopenic purpura and autoimmune hemolytic anemia are common in common variable immune deficiency. It is also associated with an increased risk of malignancy, particularly lymphoproliferative diseases. فإذا عندنا recurrent infection, عندنا bronchiectasis, عندنا autoimmune diseases. خلي المهم صفحة بس يزيد الautoimmunity من صفحة. Increased risk of malignancy. Globulin should be in conjunction with protein and urine electrophoresis to exclude secondary causes of hypogammaglobulinemia. B and T lymphocyte subsets should be measured, and the specific antibody responses to known pathogens should be assessed by measuring IgG to antibodies against tetanus, H. influenza, and strep pneumoniae, اللي نتوقع انه البادي يعني الجسم يتعرض لها سابقا. If specific antibodies against those are low, so immunization with the appropriate killed vaccine. It is important that you should, and then measuring the antibody at 6 to 8 weeks later. Management involves aggressive treatment of infections, and prophylactic antibiotic may be indicated. An exception is the deficiency of IgA, which is usually does not require treatment. The mainstay of treatment in most patients with antibody deficiency is immunoglobulin replacement therapy. Benefit of immunizations are limited because of the defect in the production of IgG. And as in all primary immune deficiencies, live vaccines should be avoided. هاي العبارة جدا مهمة. You should always use killed vaccine. You should not use live attenuated vaccines. Now we come to the fourth part of immune deficiency, which is primary T lymphocyte deficiencies. These are a group of diseases characterized by recurrent viral, protozoal, and fungal infections. And some are also associated with defective antibody production because of the importance of the T cell in providing help for the B cells. These disorders generally present in childhood. Examples include the Georgie Syndrome. Deficiency is accounted for by failure of the thymic development. Affected patients tend to have very low number of circulating T cells despite the normal development in the bone marrow. Importance of the thymus in the maturation of T cells. It is associated with multiple developmental abnormalities, including congenital heart disease, hypoparathyroidism, tracheoesophageal fistula, cleft lip, and palate. Bare lymphocyte syndromes. This is caused by mutations in a variety of genes that regulate expression of the HLA molecules and characterized by recurrent infections and systemic vasculitis because of uncontrolled activation of the natural killer cells. NK cells هم natural killer cells. عندنا severe combined immune deficiency. This results from mutations in a number of genes that regulate lymphocyte development with the failure of T cell maturation with or without accompanying B and natural killer cells maturation. All deficiencies include the principal tests for the T lymphocyte deficiencies are the total lymphocyte count and quantification of the individual lymphocyte subpopulation. Serum immunoglobulin should be measured لأنه قلنا إنه T lymphocytes will help B lymphocyte for production of immunoglobulins. Second line functional tests of T cell activation and the proliferation may be indicated. Patients in whom T lymphocyte deficiencies are suspected should always be tested for HIV infection. Management. Patient with T cell deficiency should be considered for anti-pneumocystis and antifungal prophylaxis, pneumocystis jirovecii, and they require aggressive management of infection when they occur. Immunoglobulin replacement is indicated for those who are associated with defective antibody protection, and stem cell transplantation or gene therapy may be appropriate in some disorders. Autoimmune lymphoproliferative syndrome. This causes autoimmune mediated anemia, thrombocytopenia, and neutropenia. Other features include lymphadenopathy, splenomegaly, and a variety of other autoimmune diseases. Susceptibility of infection is increased because of neutropenia. اوكي اكو سؤال لحد هنا؟
شكرا دكتور.
تمام. نجي الى موضوع هو secondary immune deficiency. It is not related to the genetics of the body, not related to the production from the body. Something happened to the body caused this immune deficiency. اولا physiological اللي هو الايجينج او البريماتوريتي او البريجنسي. Infections mainly HIV, measles and mycobacterial infections are other examples. Iatrogenic يعني made by the doctor or the medical team by giving immunosuppressive therapy, antineoplastic agents, glucocorticoids, stem cell transplantation, radiation, and anti-epileptic agents, as part of treatment of other diseases. يعني these are indicated in the treatment of other diseases, ولكن side effects of these medications is the immune deficiency. Malignancy is also a cause of secondary immune deficiency. مثلا B cell deficiency including leukemia, lymphoma, and myeloma, and solid tumors, and thymoma. Biochemical and nutritional disorders such as malnutrition, renal insufficiency, diabetes, and specific mineral deficiencies such as iron and zinc. Other conditions such as burns and acyclemia or hyposplenisms. يعني واحد يعني had an operation for spleen or other diseases and he become acyclinic, or يعني under certain disease that cause hyposplenism. إن شاء الله تأخذوها. يعني the spleen is present anatomically but functionally it is not acting, so he will have immune deficiency. عندنا موضوع مهم اسمه periodic fever syndromes. صحيح هم rare, but they are important to know about. These are characterized by recurrent episodes of fever and organ inflammation associated with an elevated acute phase responses. These include familial Mediterranean fever, mevalonic aciduria أو نسميه mevalonate kinase deficiency, TNF أو tumor necrosis factor receptor associated periodic syndrome. FMF, this is the most common of the familial periodic fevers and predominantly affecting the Mediterranean people, Turk, العرب, الأرمينيans, كلهم اللي داير مداير الميديترينيان اللي هو البحر المتوسط يكونوا معرضين إليه. FMF is characterized by recurrent painful attacks of fever associated with peritonitis, pleuritis, and arthritis, which last for few hours to 4 days and are associated with markedly increased C-reactive protein levels. Symptoms resolve completely between episodes. And most individuals have their first attack before the age of 20. The major complication of FMF is AA amyloidosis. هاي العبارة مهمة. Colchicine significantly reduces the number of febrile episodes in 90% of patients, but it is ineffective during the acute attacks. Mevalonic aciduria due to mevalonate kinase deficiency and was previously known as hyper-Igd syndrome. It is an autosomal recessive disorder that causes recurrent attacks of fever, abdominal pain, diarrhea, lymphadenopathy, arthralgia, skin lesion, and aphthous ulceration. IgD and IgA in the serum levels may be persistently elevated, and the seroactive protein levels are increased during the acute attacks. Standard anti-inflammatory drugs, including colchicine and glucocorticoids, are ineffective in suppressing the attacks, but interleukin-1 inhibitors such as the anakinra and the TNF inhibitors such as etanercept may improve symptoms and can induce complete remission in some patients. The TNF receptor associated periodic syndrome, نسميها TRAPS, also known as Iberian fever, is an autosomal dominant syndrome. The presentation is with recurrent attacks of fever, arthralgia, myalgia, serositis طبعا يعني pleuritis, pericarditis, peritonitis, and rashes. Attacks may be prolonged for 1 week or more. During the typical attack, laboratory findings include neutrophilia, increased seroactive protein, and elevated IgA levels. The diagnosis can be confirmed by low serum level of the soluble type tumor necrosis factor receptor and by mutation screen of the TNF-RSF1A gene. Major complication is amyloidosis. Regular screening for proteinuria is advised in order to try to prevent amyloidosis. Acute episodes respond to systemic glucocorticoid, تختلف عن الباقيات. Therapy with interleukin-1 inhibitors such as anakinra can prevent the attacks. أكو سؤال على هذا الموضوع؟ شباب أكو سؤال؟
لا دكتور عشتي.
نجي إلى موضوع اسمه الأميلويدوسيس. Amyloidosis is the name given to a group of acquired and hereditary disorders characterized by the extracellular deposition of insoluble proteins. It is caused by deposits consisting of fibrils of a specific protein linked to glycosaminoglycans, proteoglycans, and serum amyloid. Acquired systemic amyloidosis, reactive amyloidosis, AA amyloidosis, there is increased production of serum amyloid. Light chain amyloidosis, AL amyloid, dialysis associated A beta 2M amyloidosis, senile systemic amyloidosis. هذول نسميهم acquired systemic amyloidosis. The other part أو type نسميه hereditary systemic amyloidosis. Amyloidosis clinical features include nephrotic syndrome because of precipitation in the kidneys, cardiomyopathy because of precipitation in the heart, peripheral neuropathy because of precipitation in the peripheral nerves, and should be always considered as a potential diagnosis in patients with these disorders when the cause is unclear. Diagnosis is established by biopsy, which may be of an affected organ or from the rectum or subcutaneous fat، لأن الركتم والسبكوتينيوس fat هم accessible يكونون as deposition of amyloid sites. The pathognomonic histological feature is apple green birefringence of the amyloid deposits when stained with Congo red dye and viewed under polarized light. Immunohistochemical staining can identify the type of amyloid fibril present. Quantitative scintigraphy with radio-labeled serum amyloid P is a valuable tool in determining the overall load and distribution of amyloid deposits. هذه صورة للأميلويد، هذه صورة للpolarized light microscope and stained by the Congo red stain, a certain type of stain. Management of amyloidosis aims to treat and support the function of the affected organs and in acquired amyloidosis to prevent further amyloid deposition through treatment of the primary cause. نعالج the primary cause and we prevent further deposition. When the latter is possible, regression of the existing amyloid deposit may occur. لما عندنا underlying primary cause. عندكم سؤال؟ اوكي اذا ماكو سؤال
دكتور بس خارج المحاضرة
يعني
دكتور سؤال خارج المحاضرة ممكن؟
اي بس ثواني. مال التشست بين دكتور رافد المفروض يعطيكم اياها؟
والله دكتور ما اعرف.
محاضرة ثيوري غير تقصد لو
لا دكتور تشست بين.
اي يعني كثيوري يعني محاضرة باطنية مو كلينيكال.
اي كثيوري.
والله هو يعني لو تسألون دكتور زيد لأن هو المقرر مال المرحلة الثالثة. شوفوا دكتور زيد والله أنا هم أسأله إن شاء الله أعطيه خبر.
تمام دكتور.
أوكي نلتقي إن شاء الله الخميس القادم على المحاضرة الثانية. الأحد إن شاء الله ياخذكم دكتور زيد. يلا شكرا جزيلا إذا ما عندكم سؤال.
شكرا
دكتور.
هلا بك.
شكرا